So I'm going to spend the next few moments giving you a little bit of insight into the sequencing of drugs in myeloma, and I think that one of the conclusions is going to be at the end that we don't really know the right answer. And that's because the number of patients that we have to make these judgments from are very, very small. And there are, in fact, subtle differences between many of these agents that may make the presumption of understanding mechanism of action and mechanism of resistance a little bit more challenging. So these are my disclosures. And these are fun slides to talk about because over the 20-plus years that I've been in the field, we've seen an explosion in the number of different approaches for myeloma therapy. But I think if you really begin to look at the last 2 to 3 years, what we've seen is really an enhancement of the immune therapy platform, which I would argue actually began back in the early 2000s when we had thalidomide and lenalidomide and then pomalidomide. Got better with the monoclonal antibodies like the anti-CD38s and the SLAMF7 targets, but really has come into its own now with the bispecifics and the CAR T cells. And so much of what we're going to focus on is how do you think about sequencing these where you have multiple agents or approaches that target the same receptor, and how do you maximize the benefit for a patient over a longer period of time. So let's start off with the data we have prior to the current labels, if you will, for bispecifics and CAR T cells. And this really looks at the CD38 monoclonal antibodies in combination with either pomalidomide and dexamethasone or carfilzomib and dexamethasone. And you see those trials listed below here, and in every one of those, the triplet is better than the doublet. And that's not really new information. Most of this data actually was generated pre-CD38 antibodies becoming standard of care for newly diagnosed myeloma. And I know that at many centers in the US, for instance, it's been standard of care for at least the last 3 years, if not even longer. At our center, we've been using anti-CD38 antibodies as part of the induction since 2017. So the PFS, the hazard ratios, all of that may be off the table when you get some exposure to an anti-CD38 as part of the initial induction therapy. And then again, if you look at prior lines of therapy, this confirms some of that data before that I discussed in terms of median progression-free survival for len-sensitive versus len-refractory. I think in the modern era, almost nobody after induction therapy is len-sensitive. Everybody is likely progressing on lenalidomide maintenance in one form or another. And I think the question is, did they have brief exposure to an anti-CD38 or did they have prolonged exposure to an anti-CD38? But I think in most cases, patients are likely PI sensitive, which may be driving decisions about how to manage patients in the early relapse. Now, an area that I think is a little bit more exciting, however, is the 11-14 subset. And while neither in Europe nor in the US do we have an FDA label for the use of venetoclax, I think that the 11-14 subset really does represent a unique area where precision medicine in myeloma is in fact quite effective. And what you see in these trials looking at either ven-dara-dex or bortezomib in combination with venetoclax and in combination with dara and dexamethasone, you see a pretty substantial improvement in PFS through the use of this precision medicine approach. And certainly in my practice, and I'm sure others in the US, I try to use venetoclax as early in the disease course as I can to maximize the benefit in an 11-14 patient. Only in an 11-14 patient. So I think there is a pretty unique role for this, even in the context of all the stuff that we've talked about that is, in fact, on label. But I think the sort of punchline is that that's all old news. All of that stuff is now far less interesting. Nobody wants to hear how I talk about first relapse with CD38 or PIs or IMiDs. What they really want to talk about is how do we use all this new stuff. So while I just talked about the newest, oldest stuff, what everybody wants to hear about is the newest stuff in general. And so I think when we begin to think about sequencing, particularly with the limited data sets that we have, it's really important to put these 3 considerations topmost in your mind. And the first is, how do you maximize short-term response? We know that often in third line or later, getting a response is critically important to patients surviving. If you don't get a response with what you do next, you may not get a shot to treat them again. So maximizing that short-term response is important. The second is, how do you maximize that short-term response but not limit what you're going to get in the long term? So is there a way to think about maximizing both today and tomorrow by choosing the right sequence? And obviously, the net result of those first two principles should be to improve progression-free survival and, in late lines of therapy, overall survival. And that's a caveat that I think is really important. We keep talking about overall survival, but in 1 to 3 prior lines of therapy, the median survival of a myeloma patient in 2024 is well over 15 years now. And so expecting OS benefits from what you do in first-line therapy when they're likely going to get second and third and maybe even fourth-line therapy is a little unreasonable. But in later-line therapy, I think OS is a reasonable endpoint to begin to look at. So the first question that we have to answer, and as a field, we have not answered this question, is what does it mean to be resistant to a BCMA-directed therapy? We know that to be resistant to bortezomib, or to be resistant to carfilzomib, or POM or LEN, progression on therapy or within 60 days of therapy is the way the IMWG defines that. But if you get a CAR and then you get no therapy for 3 years, is that patient really resistant to BCMA-directed therapy? So much of the data I'm going to show you on retreatment didn't stratify patients by time of response to the previous BCMA-directed therapy. That's a really important point, because somebody who progresses within 60 days of a CAR is biologically very different from a patient who progresses 36 months after a CAR. And in the second, I may be much more comfortable treating with a BCMA bispecific. In the first, I'm not sure that BCMA is still there in that first patient, because they clearly blew through that initial BCMA-directed therapy. And we now know from laboratory data from a couple of different sources that a patient who progresses on one T-cell engager, whether it's teclistamab or elranatamab or Linvo or other drugs in that T-cell engager category, doesn't mean that they're necessarily not going to respond to the next one. And the reason I say that is the mutations in the receptor may be different. The binding sites for each of these three most likely to be available very soon, T-cell engagers targeting BCMA, is slightly different. So resistance to TEC may not necessarily mean resistance to ELRA or Linvo, and we don't really have good understanding of what the most common mutations are to be able to answer that question. So this is sort of the nice garden variety discussion of T-cell engagers in myeloma. We know that T-cell engagers do a number of different things, but one of the things they do is bind directly to CD3 on a T-cell, bring that in close proximity with a myeloma cell or any other cell that expresses BCMA, and any other cell is part of why the hypogammaglobulinemia and the impacts we see on immune function are so much more suppressed in the context of a BCMA-directed therapy than perhaps GPRC5D or FcRH5 or CD38. You then result in T-cell activation, proliferation, and differentiation, and you see all these other areas here in terms of upregulation and activation of immune function, many of which can be enhanced with the use of either an immunomodulatory agent or a cell mod. And so in my mind, trying to maximize the benefit of immune therapy should in fact be partnered with these two classes of drugs, which are different and have different potencies, but certainly are important things for us to consider. Now, what are the reasons or mechanisms of failure for immune therapy? And so they're really, I break these down into three categories. The first is T-cell characteristics, meaning the absolute T-cell count. This is where I know that our lymphoma colleagues use a fair amount of alkylators, specifically bendamustine, as part of their treatment. In myeloma, we try and avoid that at all costs because we know that that is a major mechanism for failure to collect enough T-cells to make a CAR T-cell product. So differences between these diseases, I think, are really important. the CD4 to CD8 ratio, and again, the impact of prior therapy. Obviously, the more prior therapy you've had, the more, in theory, the more dysfunctional the T cells are. Though, as you'll see in a few moments, if you give a T cell engager in 6th-line myeloma therapy, the response rate's pretty good. So are those T cells really, truly dysfunctional? I don't know. I would argue that I don't think they are. But certainly that's something to consider. You can think about the microenvironment as another potential mechanism of inducing resistance, whether it's immune suppressor cells, the impact of bridging therapy on the microenvironment, or the lymphodepletion and the conditioning regimens not being suitable enough to allow those T cells to come in and expand after infusion. And then again, this last box in the bottom right, what I think you see again is antigen expression levels. We know that high levels of soluble BCMA can act as a sink, particularly for T cell engagers, and this may be a prediction of poorer response to BCMA-directed therapies, although there are many that argue that's purely a disease burden effect, not necessarily an indirect binding effect. So teasing those two things out certainly is something that remains a challenge. High-risk cytogenetics and ultimately extramedullary disease remains one of the greatest challenges that I think we fight, even in the context of CAR T cells and T cell engagers. These often predict for very short responses to both of these agents. So let's look at the available BCMA-directed agents, and you can scratch out elnuctamab because that has now been shuttered, if you will, in terms of moving forward in phase 2 and phase 3 trials. But what I think you'll see in purple are the two FDA and I think EMA-approved T-cell engagers, and that's teclistamab on the left and elranatamab to its right. Under the progression-free survival, if you'll notice, it says not evaluable at 12 months. We know for elranatamab now that is 17 months with a follow-up, and the DOR is likely longer than 17 months. We don't have that follow-up. But in general, you'll see that the overall response rates are similar. The rates of CRS and ICANS are relatively similar, and in my mind, ultimately PFS is going to drive what the real differentiators are between these agents. Again, recognizing it's hard to do cross-trial comparisons when you have small, single-arm phase 2 studies. If we look at beyond BCMA-directed therapies, you see talquetamab, which targets GPRC5D on the right. What you'll see there is its overall response rate. And so when we think about using a bispecific after a prior bispecific, talquetamab is certainly part of that equation because you can change the target, GPRC5D instead of BCMA, and use that to try and drive a higher response rate with a different, perhaps non-perturbated target. However, the T-cell clone, the T-cell fitness, the T-cell health then becomes a question. And going T-cell engager after T-cell engager, or do you give something else in the middle? I think those are questions that we're going to begin to ask, particularly in the context of real-world data in the coming years. So what are the current sort of immune therapies, if you will, in the context of relapsed and refractory myeloma? These are data on ide-cel, cilta-cel, teclistamab, talquetamab, and elranatamab, and certainly in the United States, we now have more recent approvals for ide-cel and cilta-cel that move them into earlier lines of therapy based on trials, randomized phase 3 trials, testing their efficacy in early relapse versus standard therapy. And this means that the options and the questions on sequencing are going to continue to get more and more complicated. So what trials do we have that really evaluated, for instance, elranatamab in the context of previous BCMA-directed therapy? And what I think you'll notice here is that the N, other than magnetism 3, is relatively small. In magnetism 1, you've only got 55 patients. You've got a few in magnetism 2. You've got a bigger N in magnetism 3, but the numbers of patients with prior BCMA exposure is very small in each of these. And we're going to go through those in a couple of series here. So this is data with elra after previous BCMA-directed therapy. You can see the overall response rate, depth of response, DOR, all of that data listed on the left. And then on the right, you can see that in bar form here. And what I think you want to put this in reference to is that the overall response rate for elra without prior exposure to a BCMA-directed agent is in the mid to upper 60s. So there is a drop in the overall response rate. But to me, the real question is about median PFS. Overall response rate is not the whole story. And what you're seeing here is median PFSs of 5.5, 3.9, and 10 months, whether they got a CAR, ADC, or they got any prior BCMA-directed therapy. Now, to me, again, the question is, in those CAR patients, was it a short response to a CAR or a long response to a CAR? We don't know the answer to that data, and then you get into much, much smaller numbers of patients. So in order to really answer these questions, we're going to need larger data sets to help us tease through a lot of this. What about looking at teclistamab in this context? This is the cohort C of Majestic-1 in patients with prior BCMA-targeted therapy. And again, you'll see the overall response rates, 55, 53, and 52%. Compare that to mid-60s for BCMA naive in the Majestic trials. And again, the PFS is shorter in these patients than it is in the traditional teclistamab in the BCMA naive patient population. Here's some data on real-world teclistamab response by prior BCMA-directed therapy. This is looking at ADCs, CAR T-cells, ADC and CAR T-cells, or ADCs and other. And what you'll see that in general, the overall response rates are lower. When you look at that third column, while the 80% certainly does look good, it's only 10 patients. And again, I suspect most of those patients were long-term responders to a CAR, where I think you're more likely to be able to re-challenge with a BCMA-directed T-cell engager. And finally, let's look a little bit at the CAR T-cells after BCMA-directed therapy. This is data from the CARTITUDE-2 trial in cohort C. You can see that a number of patients got both ADCs and bispecifics on the right. They did tend to be a little bit more advanced if they got both of those. You can see that some got an ADC or a prior bispecific before they went on to get a CAR T-cell. And if you begin to look at overall response rates, again, much lower than we would expect to see overall, very small numbers, 61% in prior ADC and 57% in prior bispecific. But if you look at median PFS, 9.5 and 5.3 months. Compare that with what we expect in this patient population, BCMA naive, somewhere around 30 months. So significantly shorter if you had something else before. And so I think these are, and the last one that I'm going to have here is really talking about ide-cel post-BCMA-directed therapy. You can see the difference between the purple and the green here. Any prior BCMA therapy, the median progression-free survival is only 3 months compared to 9 months. So again, overall response rates can be misleading. At the end of the day, it really does come down to durability of those responses in these patients. So here is some real-world data looking at that same question. If you look at ide-cel real-world, median PFS is 2.7 months with any bispecific antibody previous. Again, that's an N of only 4, so relatively small numbers. But I think this fits the theme that I've been talking about before. What about talquetamab? Targeting a different receptor. So GPRC5D instead of BCMA in this context. You'll see here that there were, in fact, a number of patients enrolled who'd had a prior T-cell engager. The overall response rate was 62.7 months. You can see 72 months, or 72% in patients with prior CAR T-cell therapy. So this may be slightly different. But again, the question is how many of them got them immediately preceded by a CAR or by a BCMA-directed bispecific, or was there a treatment gap between them that allowed T-cells to recover and perhaps be more effective in that context? And then here is another data set looking at CAR T and subsequent therapy after talquetamab. And what I think you'll see is that the overall response rate for a BCMA-directed CAR was about 77%, and you can see the response rates to other therapies here. Whether this is simply a lines of therapy question, or is this an impact on a T-cell engager impacting subsequent therapy, we don't know. But again, we need larger data sets with more robust follow-up to really be able to answer some of those questions. So what are the remaining questions as I begin to wrap up here? I see I've got just a few seconds left. And so I think the first is that mechanisms of resistance to BCMA-directed therapy are, in fact, quite different. We do see mutations in the BCMA receptor that can occur at a number of different places, not as much loss of BCMA expression as is seen in lymphomas. So the mechanism of resistance may be mutations in the binding site that may prevent, for instance, one T-cell engager from binding, but may not prevent a second T-cell engager from binding. We do potentially see loss of BCMA. This tends to occur in patients with 17p deletion, where they can acquire 16p deletion, and BCMA is on 16p. Fortunately, it's not a common event, but it can occur, probably on the order of 5 to 10%. And as we use these agents more and more, particularly in the high-risk cohort, we may begin to see some of those challenges in the future as well. So I think the considerations in sequencing are as follows. Progression is likely different for a T-cell engager, which is continuous pressure on the clone, as opposed to a CAR T-cell, where you give it and you stop therapy, and hopefully 2 or 3 years later is when they relapse. In those patients, you may be able to come back with a BCMA-directed therapy again. The optimal sequence, and I think all of us will say that, is if you're able, give a CAR T-cell first to maximize that first remission, and then think about using a different target next, and then come back to BCMA perhaps after that, using a T-cell engager or an antibody-drug conjugate. And again, it really depends on the mechanism of failure, and we don't really understand what those are. So I want to leave you with this final context here, and that is MRD is the big buzz, not just at this meeting, but in general, with the ODAC in the US and the FDA saying MRD can be an endpoint. But MRD is just part of the story. At the end of the day, MRD is a way to get a surrogate for PFS. And PFS ultimately is what we need to look at, which means it's not MRD at one time point, it's sustained MRD negativity that's really important. And these are our goals of current therapy if we're going to ultimately cure patients. So with that, I will stop, and again, thank you for your attention. Okay, I think we've got a couple of post-test questions here. Oh, you're doing that. Okay. All right. In the real-world study, which type of prior BCMA-directed therapy was associated with the highest response to subsequent teclistamab in patients with relapsed and refractory myeloma? A, antibody-drug conjugate, B, CAR T-cell, C, antibody-drug conjugate plus CAR T-cell, or D, antibody-drug conjugate plus other therapies? Okay. CAR T-cell, I actually think it's C. I think it's the two together, and they were put together in the same bucket. So it was mostly the CAR T-cells in this context. Next question. Okay. In the real-world analysis of ide-cel in patients with myeloma, which of the following factors was associated with a shorter PFS and overall survival? Low-risk cytogenetics, penta-refractory disease, presence of extramedullary disease, or prior BCMA-targeted therapy? Okay. All right, good. I think we're good. All right, I'll sit down and we'll...
Yeah, thank you very much.